We're just going to give another few minutes for people to dial in. Good afternoon, everyone. I'm just going to get us started. It's just after the hour. Roisin Connolly is my name. I think many of you will be familiar with the UCC Cancer Seminar series, which we've been running now for the last few years here in Cork. And this was initially established as a collaboration between UCC and our affiliated regional hospitals to recognise the major expansion in cancer care and research over the last decade and try to integrate further our academic and clinical partners. And so we're delighted that we have really the fourth series being opened today by a distinguished speaker from MD Anderson, who I'll introduce in just a moment. I'm just going to remind people to keep yourselves on mute during the hour. If you have questions, if you can put them in the chat or raise your hand towards the end. And we hope to have 5 to 10 minutes at the end for questions. Today, we just have one speaker. This is our inaugural lecture for the year. And we're delighted that Dr. Chung is speaking in regards to personalising cancer care using artificial intelligence and data science. So I'll introduce Dr. Chung. Dr. Chung, you're very, very welcome to our series. And just to note that Dr. Chung is the Vice President and Chief Data Office and Director of Data Science Development and Implementation in the Institute of Data Science in Oncology at the MD Anderson Cancer Centre. And she is a clinician scientist, an associate professor in radiation oncology and diagnostic imaging. Her clinical expertise is in the area of CNS malignancies, and she also has a computational imaging lab focused on quantitative imaging and modelling to detect and characterize tumours and toxicities of treatment to enable personalised cancer treatment. And she has developed and leads the institutional efforts at MD Anderson to enable quantitative measurements for clinically impactful utilization and interpretation of data through a team science approach. She has led several multi-D efforts internationally to improve the generation and utilization of high-quality quantitative data to drive research and impact clinical practice. And she has a role as Vice Chair of the Radiological Society of North America, Quantitative Imaging Biomarker Alliance. She's also co-chair of the Quantitative Imaging for Assessment and Response in Oncology Committee of the International Commission on Radiation Units and Measurements, amongst many other accolades. She is an active educator and mentor and has a passion especially to enable the growth of the STEM area, including in her role as the chair of Women in Cancer. So Dr. Chung, we would invite you to share your slides. Thank you so much for being with us today, and we'll let you go ahead with your presentation.
Thank you. Thanks so much for the invitation. It's a pleasure to be here. I will be talking more about data than AI itself, but as many of you can appreciate, the data is actually the piece where it starts. So if we don't get good data, it's the whole garbage in, garbage out philosophy. And so how do we start to empower our data, and what are we dealing with when we think about using our data within personalized cancer care? And we really start to take an approach of building up the culture that's grounded and looking at the context around the data. That's what I'll be talking about today. So if we look at the exponential growth of data, we all talk about how much data is being created. We have to start thinking about how much of this is actually usable, helpful data versus adding to the noise of the pile of data that the potential data that we may have. And so this was a great article highlighted in JAMA that actually demonstrated the prevalence and sources of duplicate information. I'm sure many of you who are clinicians out there have been guilty of doing this. I have as well, of the copy and paste. And so if you start to copy and paste and you don't do it thoughtfully, you can actually copy and paste and propagate errors within your medical note. And so you can see the proportion of duplicate errors and duplicate text. Some of those that may be errors that are getting duplicated in there. And so when you start to think about how you're going to leverage AI, and we talk about things like large language models that can scrape through your EHR notes, just start to think about what are we actually dealing with in the EHR notes as we start. And so we need to start to think about how are we actually going to systematically and foundationally change how we're documenting if we're going to truly leverage the power of our data. For those of you who are starting to explore into data science, or even before data science, any sort of research question, I'm sure you have come across this challenge, the findability of data. So you're looking for a specific cohort of patients, you're wondering if the data exists out there, you're trying to figure out whether you need to create this yourself or can you actually access data that's already been produced. And you start the hunt and you may email or call someone that you know, they point you to another person, and you go through this chain of events to try to find the data. And sometimes you end up coming full circle to the first person that you've asked all the way at the very start. And so starting to think about how do we actually improve that findability. A second point is that you may get pointed to data and you may actually finally get access to it, and you celebrate that you've finally gotten access to this potential data that you're going to utilize. Once you open it up, you realize it's actually messier than you thought. You're not so sure how much you can trust it. It's of unknown quality and not organized the way you understand it. And so the headers of your columns and rows may not be defined. So then it starts taking a lot of time to actually clean through the data. And as you may have heard the statistics, 80% of data scientists' time today are actually spent cleaning and curating data versus doing the data science in itself. Finally, you may have taken the time and invested your efforts to actually go through this data and clean and curate it. And then you realize that the data set's not as big as you thought it was. It's 3 distinct data sets that really cannot be combined together. And I can explain sort of the reason why the contextual pieces become relevant in terms of making sure that you are gathering data sets that truly are compatible and can be combined in a meaningful way. For example, if you were combining blood pressures or heart rates of patients who are in the ICU with a very high frequency of collection versus patients who have heart rates on their Apple Watch, and not knowing whether the person's on a treadmill or lying in bed could really add noise to what patterns you're looking for in the data as you're analyzing through them. So when we start to think about data wrangling and when we want to use this data, I'm sure these bubbles will probably resonate with many of you, wasted hours struggling, scoping out the projects based on whatever data that you may already have available, become frustrated trying to access the data that you may have found, trying to find that data, struggling to get through the hours of cleaning that data and exhausting resources to the data only to find out that it already existed somewhere, but you just didn't know about it until after the fact. And so these are common challenges of taking that last mile strategy, trying to get to the useful data and clean data right as you need to use it. The challenge with the last mile strategy is, as I said, the volume of data is exponentially growing. And so if you invest your efforts to cleaning that data after it's been produced, you're exponentially increasing the amount of work that you need to invest in getting to clean data versus taking the first mile strategy. And so this is what we've been really investing in over the last several years. The vision at MD Anderson is to tackle data at the first mile to empower our teams to maximize value and impact our data to serve our mission. And it's really growing a data-centric culture. And I'll talk a little bit more about culture and why this is so important in the data era, and increasing that data literacy across organizations, across the community that you want to collaborate around. It's enabling robust data stewardship. So we added a new core value at our institution, stewardship. We took that and really applied it to data. So what does data stewardship mean? It means making sure that your data is protected for your patients, often with clinical data, and making sure that you're stewarding that data appropriately. But if you give the analogy to financial stewardship, it's not only protecting that asset, that data. Bring value from that data is to also meaning that you use it and make sure that it's used responsibly in a way that you need to grow the knowledge and serve our mission. And so it's both using appropriately, obviously with appropriate access points and governance, but also protecting it in a meaningful way. And so it's both sides, not just protecting and keeping it and storing it away. Building confidence in our data collaborations. And this means bringing some level of transparency of what we're planning to do, having that agreement up front, having the attribution of the contributions made to reduce data territorialism. Co-developing an institutional data strategy to grow that value. You can do many things with data. Everyone is very excited. You can go in 1,000 different directions and go a net movement of 0. So we need to start to make strategic decisions around how we're going to prioritize our data efforts, and strategically making external data collaborations. Advancing data management and analytics, and this is where we're building out our data management system called Context Engine, and enabling exceptional data and metadata science. And I'll talk a little bit more about metadata in the later part of the talk. And this is really being supported through the Institute of Data Science and Oncology, supporting our faculty to really tackle more complex questions with our data. So I'll pause and talk about culture. So this is an acronym that I came up with in terms of the definition of culture. And I think this really applies to data, but it applies to many other things. And that culture is a common understanding in language and thoughts and motivations to unfetter relationships across the ecosystem. And the language part is important because when we think about people, all the people on this call coming from different environments, and even within medicine, if you're in a different department and a different practice, you may use different terms to mean the same thing. And so we learned this during the COVID pandemic. You know, the number of days of admission can have multiple different definitions depending on how you count your admission and how you count your number of days. Sometimes people will call the tip of midnight being the next day. And so if someone's been admitted at 11:55, they've been admitted technically for 5 minutes, but on the documentation, it will say 1 day. And so that's very different than making it a 24-hour day. And this is where the semantics and the syntactic interoperability of how we're actually capturing our data boils down to some of the cultural aspects and making sure that we're communicating with each other to know that we can actually truly combine apples to apples or apples to orange and bananas and pineapples when it comes to different data sets coming together. And so this common understanding in our language and our definitions does get boiled down to cultural differences and practices, not only countries, but across different areas of science and different fields. And so this is where we need to start to think about and start to clarify rather than making assumptions as we combine data. Now, when you think about big data, a lot of that nuance is lost. And so this is where we really need to start thinking about how are we actually leveraging our data moving forward. So this is our ecosystem. This was at the start. We were in silos, much like everyone else, and we're moving slowly towards finding a more harmonized vision. But this start is where most people are, where there's disparate data sets, you have uncoordinated approaches to collecting or cleaning data. The lack of standardization or harmonization really leaves you with uncertainty in the quality of that data, what it actually means. As I said, those column headers may mean something very different depending on where you've gotten that data. Duplicating work. A great example was, again, during the pandemic, when everyone was trying to do COVID research, everyone was probably going to the first, 20, 50, 100 cases around, and they were the same patients, but everyone's collecting the same data elements from those patients. And so what we actually did was go through and generate a large umbrella IRB, and we started to coordinate that data request and data flow and the questions that we're asking so that we didn't have to duplicate the work across multiple labs. I'm sure in cancer, again, you've got different areas working on the same patient data sets, particularly in the era of immunotherapy where it starts to cross across different histologies. And you may be working on similar patient data sets and curating, but curating the data with slightly different definitions, enough so that there have been publications out there coming from the same institution but with very different findings depending on how you've actually collected and defined your data elements. So we need to start to think through how are we going to harmonize these sorts of questions and harmonize the data collection so we can start to gather true knowledge as opposed to patterns in data based on how we've actually defined our data elements themselves, and they could be very different. So understanding the origin or the provenance of that data, understanding how things have been defined and flowed will lead to direct effect on your actual insights. And so we've started to build through to the data ecosystem of a future state where there's a single view of the data, but a single source of that data that's trustworthy, people understanding through building out data literacy, thinking about those observations in context. And the reason for the observations in context being relevant is that you can have multiple definitions of a particular data element, but you need to be aware of what that definition is and how that data has been collected. So A, you can actually select the appropriate data to use, the appropriate source data that you may want to leverage as you're building out an AI model, for instance, and how and whether that it really applies to the specific research question that you are asking, or operational question, or an educational question. So you can actually start to leverage the data that's been curated with enough context that you can actually ask the relevant type of question that you are after with that data set. This really starts with the data literacy, so people understand what contextual pieces need to be gathered. And it also starts to employ the data stewardship, so really focusing on high quality data from the point of generation through to its use, that first mile strategy. And we're building out this data management system with enabling tools that will allow for harmonized data curation and a cooperative ontology. So how do these data terms relate to each other in the bigger picture? And with a team data science approach, again, we're looking at accelerating the collaborative insights. So working together on similar questions with different lenses, making sure that there's effort and attribution. So if you track the source and provenance of the data, so the journey of that data, you can actually see who has contributed to that journey of that data. And if you give attribution to that, to the individuals involved, then that will actually help to build out the community and the teaming approach. I think that many of the data silos that have been generated is because of the lack of provenance and the lack of attribution. People fear that people will just take the data and hours that they've worked on to actually clean that data and just go and utilize it without any attribution. So we're starting to proactively and intentionally build out an attribution system so we can actually build out the community that will work together. And this requires a culture of teaming and stewardship, because at the end of the day, data generation in reality is really messy and labor intensive in healthcare at this point in time. And this is because, we've started from a qualitative, unique clinical setting where each note is written much more like a paragraph, and there's very little structuring. In order for us to really leverage the technology that potentially excites us around AI and machine learning and deep learning and even the large language models, to really do that meaningfully, we do need to start to standardize and generate structured reporting. The challenge here is that this is true of any technology, that as we start to think about moving from a unique clinical artistic perspective to that structured reporting, there is a period in time where it feels like we're a bunch of assembly workers. And I would say to the clinicians out there who are suffering along with me, I think that we're at the peak of this hump. I think that but having said that, I think if we don't intentionally start to really make efforts in generating these structured reports, this peak will be much higher than it needs to be. The faster we can start to think about how we're actually generating these structured reports with enough descriptors, we will get past this hump, because the patterns that are being taught with these large language models or AI or any other automation system is really requiring structured and consistent documentation. And the more inconsistent we are, which humans are, the more difficult it is for us to actually train these sorts of models to successfully perform. And so as we start to think about this, I've published this paper called Cancer Needs a Robust Metadata Supply Chain. I promised that I would talk about metadata. And it's really starting to think about grounding principles of how we tackle data. So the first principle is that we need to take observations in context. As I said, an example of a simple heart rate, it's a simple number. It seems like a pretty simple data element. But if you exclude the context out of that number, it can mean very different things. If someone is in aggravating pain, their heart rate is going to be higher, their blood pressure is going to be higher. So even simple things like vitals that often flow from the machine that's taking the vitals through to the EHR and can flow through to your data sets, if you don't capture the context, you're only getting surface and the number, and you may be finding patterns that don't actually mean a whole lot. So if your device, for instance, was not calibrated, and it's calibrated so it's substantially reading values that are higher or lower than the other machines, then you're going to get erroneous patterns in your data. So start to think about the context. Similarly, in the COVID pandemic, we've actually seen different regional differences. And so if you remove that context and you pool it, this is the dangers of sort of the risks of big data. There are value statements to how you can leverage big data. If you start to ignore that context, you may not get that full picture and the depth of understanding that you really want to be gaining from the data that you have. Making sure that you're thinking about data quality, and the principle that we've actually stated was around dynamic assessment of that quality. So data does not all have to be perfectly pristine in every single situation. If you're looking at big patterns, you may be okay with big, messy data, and you may be okay with the noise because you're looking at big patterns. If you're trying to make a decision about a single patient in front of you, you may want the highest quality data possible. So the quality may depend on the type of question that you're asking. And so we started to measure quality in our data to say, here are the quality metrics that we're measuring. Depending on your question, you can pick and choose which data set you feel comfortable utilizing for the question at hand, because sometimes you may want noisier data and to make sure that you're testing a model for robustness. Other times you may be wanting very high quality data in terms of actually training a model, for instance. And so the provenance is this, where the data has come from and the journey that it has taken to the point where you're using it. And this really reflects on the confidence that you have in the data. And that's why it links directly to the insights that you're going to get from your observations or data points. And this entire system works best when you've got an integrated data governance system that ensures appropriate access and attribution based on the roles and intended use, with all the descriptors of the quality and the provenance. And the underlying glue for all of this is that metadata. And here's the reference on the bottom corner if you're interested in reading more about metadata in the cancer metadata supply chain. So a little bit more about metadata. Observations in context ultimately leads to information. And that basically equates to the data, which is the content, for instance, the heart rate number, and the metadata, the context in which it was measured. And that could be everything from the date, the time, the device that was used to measure, the situation in which it was measured. Was it an average of 3 different measurements? Was it, what was the measurement device? Are you in the ICU or are you on a treadmill using your Apple Watch? And metadata really helps define the value of data. And this is an analogy that seems to resonate with many. So imagine you're an archaeologist and you're going out and you find a stone that looks really interesting. And so you decide to put it into your Ziploc bag. That stone could be considered your data point. So you've got a piece of data, put it into a Ziploc bag. You don't write what all the details that this archaeologist is writing on that bag. You may look back at that Ziploc bag 5 years later and you may have some sentimental value. You may remember that you had found this on a dig. You may not remember at all and wonder why you have it. But if you write all of the details down, this is the metadata that gives the value, knowing which dig, what longitude and latitude, which lot were you in, at what date did you find it. These are the nuanced details that will actually give value to that data. This is where the metadata really starts to define the value of that data. And data is content, but metadata is the context. And metadata can be much more revealing than the data, especially when it's collected in the aggregate. An example that I can give you is this is literally how Gmail or Google made all their money. This is what they were collecting. They were not reading your emails, but they knew who you were sending emails to. They knew which websites you were going and looking at. They weren't really paying attention to exactly what you were looking at or what you were scanning, but they were looking at the addresses and the dates and times. And so this is what they can leverage is that metadata to actually insert reminders or insert advertisements, etc. And so this is where that metadata can really be powerful. We can leverage metadata in medicine as well. And so we've started to build out our data management system, leveraging that metadata. So we've got all our data sources on the right. You can see in this diagram, this is our vision of context engine. We've got a data governance and provenance office. So we've really focused on the provenance of that data. Where did that data come from? What source and what journey? We have a dedicated ontology team, a data quality team, a legal and compliance team up front, tied to the data architecture and operations team. And then on the front facing is the data offices, where we really start to think about a consumer service where we're actually focusing on the questions that are being asked, whether it's a research question, the SPDC is a strategic partners data collaboration data office, the government and regulatory. We've got one now for clinical operations. So as people start to come with questions, we start asking enough detailed questions to say, based on your question, we know that we can actually go back to the different sources of data, and we know the different qualities of data. Again, a quality attribute could be considered metadata. And so we can actually find the appropriate data to best match with your question to help address the question faster and more effectively. Again, the data that is being used within the projects can get harmonized into our institutional resource so that we continue to grow our knowledge and we continue to iterate and iteratively improve the quality of the data flowing through our systems. So this is sort of the schematic diagram of our data flowing. You can see it looks like a solenoid, the data flowing around through and people having visualization into the context engine. And these are the different pipelines that we have. We have machine learning, AI pipelines, omics, imaging pipeline. We actually have been looking at voice and NLP and OCR pipelines, other analytics, orchestration, et cetera, et cetera. We really focus on quality at the point of ingress into context engine. And although this looks like a single repository, this is a connection and conglomerate where different groups can actually govern their own data and come together as a community. And we've really been focusing on the processes and the goals of how we're going to leverage this data and to help us guide the choices of technology. This has been a shift in recent years because historically we were really limited by the technology, and so we could only do certain things. And so we had to change our processes to utilize the technology. Today, we're actually at the luxury of being able to say, these are the capabilities we need. Let's configure the technology accordingly. And so we've started to think about how is our data going to flow with the metadata to allow for data governance. We've been looking at how we can actually measure data quality and continue that reusability of that data, and building out the tools and partnering with industry partners to actually build out those tools to allow us to utilize data in this way. Now, once we've built out this comprehensive and systematic approach, we can start to build, we're growing that collaborative data ecosystem. So through the data literacy efforts across the organization, we're connecting the research, operational, financial teams, our patients, to this overall context engine data governance and digital architecture, and making sure that we're thinking through what kinds of questions are we asking so we can leverage our data science tools and data science team as we grow out that team to really tackle those questions. And that metadata supply chain, that contextual information, will be informed by the types of questions that we're asking. So the types of descriptors that you need may differ depending on the types of questions you're trying to tackle, but it will also inform the questions themselves. So for instance, there may be patterns in our data that we actually had not noticed before. A great example of this is that historically the genomics community came together and started noticing that there were these unusual patterns that eventually got resolved as being a technical signal of batch effects. So the thing is that even though you have different groups doing an analysis and they're saying they're doing it systematically, they may be getting different results. And so if you see different patterns, you're just seeing the different patterns, the different ways of analyzing the data, as opposed to a true biological signal. So how do you start to tease out the biological signal from the actual technical noise that you're actually detecting? And so we're starting to look at that within the metadata, looking at quality of data affecting the insights, as well as the sources of data affecting the insights. So as we start to generate value and impact from our data, we're bringing together perspectives from various different stakeholders, because the types of metadata and the types of descriptors can differ depending on the different perspectives. And so we want to try to get that comprehensive view and start to prioritize what details do we need to capture around each of these data points that we're trying to collect systematically. Now, when it comes to AI, Eric Topol published this back in 2018, that there is a lack of awareness of the so-called AI chasm. It's the gulf between developing a scientifically sound algorithm and its use in meaningful real-world applications. And this is true of any technology, that there's the innovators, the early adopters, and then there's this tipping point. So if you think about what I've just been saying around data scientists spending 80% of their time cleaning and curating their data, and then building out these models, that data does not reflect the real world because it's clean, curated data. They often will train their data, they'll collect up a large data set, they'll break it up into a test batch as well as the training batch. And all the data that they're looking at, whether they're testing it or truly training it and developing it, is all highly curated, highly clean data. And so when you try to just throw it into the real world, it may or may not work. And so narrowing the gap will require the introduction of context. So bringing the context of what is the difference between the highly curated data and the real world, educating the importance of context. So if you take an algorithm that's built out of one population of patients and you try to apply it to a different population, does it really work? If your scanners are completely different, does that work? And so knowing all those contextual metadata around how that data was collected within the model building and the teams developing the models, as well as where you're trying to apply it, and finding that match, that contextual match will likely bring you to success much faster than if you just ignored the fact and try to find generalizable models overall. And this is really where things are going. So OpenAI CEO says the age of giant AI models is already over. Andrew Ng also said that, we need to unbiggen AI. We need to start thinking about smart-sized data-centric solutions, bringing the context forward. And here's a great example during the COVID pandemic where context really started to hit reality, where there were hundreds of AI tools that were built. So as the pandemic started, thousands of chest x-rays were uploaded. Everyone came together, gathered, and said, this is the an emergency, we need to share our data. So images were deposited from various different hospitals into an open source data set where people can actually build out AI models to help diagnose COVID. The hundreds of models were built through multiple, very high-powered AI labs. And yet the same mistake was made across most of them, because MIT went back and reviewed why were these models failing. And what happened was the metadata was actually ignored. So out of those hundreds of models, they all failed because, if you recall, very early in the pandemic, pediatric patients, the children were not getting sick. They didn't start getting sick until later in the pandemic. So, but they took chest x-rays of all chest x-rays that could be deposited. And so the majority of healthy lungs were actually pediatric lungs, and the COVID affected lungs were adult lungs. And so the challenge with AI is that if you don't actually think about that context and that metadata, and you just throw it in, they take it as equal. And what the AI models had been learning was the pattern that distinguished non-COVID affected pediatric lungs to COVID affected adult lungs. And so when you actually threw it into an emergency room where you're trying to diagnose adults, it was trying to decipher pediatric versus adult versus COVID versus non-COVID. And so the metadata around the age of the patient was an incredibly important piece that resulted in hundreds of AI models failing to catch COVID, because when you only expose it to adult lungs, you were getting a bunch of false positives, because the AI model had learned that the adult lungs were more likely to have COVID, which was actually true very early on in the pandemic. So this is just a real life example of how the metadata can really influence your AI training. So we started to build out a data literacy and culture course at the MD Anderson Leadership Institute, starting to grow out the awareness around metadata and context around our data, embracing our core value in terms of data stewardship and thinking about how we protect our data, ensuring our data is of high quality and reliability, keeping track of our data, ensuring our data is used to maximize our insights. Now, in order to match the data and the quality of the data and the context of that data, we really need to start to think about data probably more like water. Many people say data is the new oil. I say it's more like water, because it can be reused. And in an ideal setting, you probably would say, what data is required to answer the question of interest. So again, matching the type of water to the type of use. So if you go from left to right, you're getting really high pure water, which is true of much data that's being used to develop models today, to water that you may use to garden your garden or wash your car versus what gets flushed down the toilet. And so as you think through the data within our various different systems across our hospitals, you can imagine where you could probably put categories around which source of data would be classified as the pure drinking water versus what's in the toilet. And so if you think about building models with one and trying to apply it to another, it's probably not going to perform in the same way. So it's starting to think about the quality of that data. What is the impact of the uncertainty in that data for the specific intended use? And so if you need something where you're highly confident in the outputs, then you need to think about making sure that you've got high quality data going in. Just because you have a high-powered model does not necessarily mean you're going to get high-powered outputs if you're actually feeding it poor quality data. And so you need to make sure that you're matching the data for the intended use. And so amidst the growth of exponential data, there is useful data that will generate the greatest impact, and a dedicated first mile strategy around the data, the content, and the metadata context will inform us to help generate useful data that both allow us to use the data appropriately. This is particularly became highlighted around the large language models, where all the data off the internet was scraped with or without copyrights, with or without licensing, and there were lots of legal issues around that. So thinking about the rights to data use and being intentional about how you're going to use that data, the data quality, the data journey, the provenance, where does it come from? How does it inform attribution for people's efforts, triggering encumbrances. So if you already have data that's encumbered under contracts with sponsors, you may want to know that before you start utilizing that data so you don't violate those encumbrances. We've actually started to build out an encumbrance tracking tool, leveraging the metadata that we have. And finally, the provenance really ties back to the confidence that we have in the data, whether we're building models or are utilizing the data within those models. The ontology helps us translate the meaning across the team, allow us to have that common understanding around our language. And the context that also informs ethics and privacy for the data analytics and AI. And building a data-centric culture requires common understanding around the first principles, those team data science principles that I've described, as well as the data literacy to allow for growing data stewardship and really starting to collaborate across diverse perspectives to ask the value-adding questions and prioritizing data management efforts to drive towards a strong data strategy. So I'll end there and happy to answer questions.
Dr. Chung, thank you so much. That was absolutely fantastic and a bit mind-blowing, to be honest. I think we are in a country that doesn't have standardized electronic health records in our hospital. So unfortunately, many of us are working with multiple systems when we're trying to see patients as one thing, and then try and consider linking that with the academic side is a whole other step. So clearly this has just taken a huge amount of work and drive in your institution. So I suppose one question that I have, as we see if there's other questions coming through, and I think I know the answer, but it's more for the audience, in terms of the governance structures for MD Anderson, in terms of encompassing the clinical and the research side of your function. I'm thinking that the governance structure is sort of one structure for MD Anderson that encompasses both of those components to your work, versus do you have different systems that you're requiring to sort of bring together to enable this type of data stewardship between, let's say, healthcare and academia?
So I think that it is multiple systems. We're still in and I don't think that you don't necessarily need to be in one system. I think that the bigger challenge, so the approach that we've taken is that if we actually start to standardize how we deal with data, so the definitions that we have, if we start as a practice, start to motivate the same definitions, it can be in multiple systems and they can connect when they need to connect, but at least you know what you're dealing with and what's connecting versus this unknown connection. I think that's the bigger challenge, is that I think that many of the, other organizations or other groups that I've spoken to, they say, you've got resources and you're doing this because of, but the most challenging step of this does not take any resources. It actually takes the conversation. And I think that there's the initial intention to say, we're going to come together and start to understand what each of us are doing and start to have fairly candid conversations around what are you doing versus what am I doing, and what are your needs versus my needs. And then starting to think about, in those respective systems, how do we start to prioritize what connections do need to be made and what definitions need to be harmonized. And the harmonization piece is not throwing resources at technology at the problem, because you need to come to a consensus before you actually can throw any sort of technology at the problem. And so the first steps actually take no money or resources at all, and doesn't necessarily need any sort of change in technology. It's really the intention and the conversations.
So it's sort of mobilizing the troops on the ground to be thinking in a way, and to work together. I suppose we're starting some conversations in that regard locally as we consider a European accreditation pathway for our university hospital here in the south of the country, and it's actually pushing people to start looking at what our data managers are doing locally as they collect cancer data, how they're doing it, are there easier ways to collect it based on people talking together? So it sounds like maybe the conversation is starting here,
Yes.
and hopefully that will push us in the right direction. I know Professor Barry has grand aspirations for us to have a cancer intelligence team, for example, here, which I think is sort of along the lines of what you have. But again, starting small with the conversations and all agreeing that it's going to be important. So does anybody have any questions from the audience, or you want to make a comment?
Can I ask, Dr. Chung, so if so you have the conversations and you get going, like what is then your go-to, what will be your, in terms of building technology and our platforms, like where would you start from there? I guess it's bringing the people together, bringing the data, finding what data we all want, and then bringing it onto one platform.
I mean, I think that it doesn't necessarily have to be in one platform. I would probably start with getting a survey of, I'm assuming you already know which platforms you're dealing with and across which platforms there are. And then what we started to do was prioritize which data elements were of common need to the largest proportion of individuals for the largest number of needs. So, I mean, in cancer, the top four, I would say, are trying to get diagnosis right, staging right, treatment details, and enough detail that you can actually do some sense making. The time scale of treatment, so exactly when are these things delivered, is a trickier one than many appreciate. And then outcomes, obviously, there's the bucketed outcomes from clinical trials, but is that really how it's all documented in the clinical chart? It becomes, each of these buckets are actually fairly large. And the other thing that we actually found was that there are many groups that have large data sets that have been collected over the years. But when you ask for a written standard operating procedure of how the manual data abstractors, this is manual abstraction, do you have a clear data dictionary and clear instructions and quality assurance processes of how, so the true SOPs of how manual abstraction has been done? And it's not always there. And so I think that even just starting with that and coming to an agreement of over the common data elements of saying, this is how we're all going to define it, would actually start to really bring together a powerful data set across all of the groups that you're involved in. And so I think that that would be low-hanging fruit in terms of, doesn't really take any sort of technology or anything to actually start that conversation. In terms of the technologies that are available today, I think there are many that are available across the different needs. And so I think it would depend on your inventory of what connections do you need to make. And then, as I said, we sort of focused on what are our goals, what are the processes that we currently are practicing, and what's that transition going to look like? And then started to say, these are the specific functions that we need for whichever platform we're going to connect. And then you can actually start to shop around, because there's actually enough options out there to find the right fit for your particular needs.
That's really helpful. And I think, kind of the message that I've gotten from your presentation as well is that it's very much, we can talk about AI all the time, but it's where we get that AI from. And it really goes back to basics, back to that data, and really trying to hone in on how we get that data to actually use it in an AI way. I see Darren's camera's on. I'm wondering, Darren, do you have any comments?
Yeah, absolutely. That was fantastic. I have to say, and thanks, Ashley. I'm going to be honest. I've never heard a talk with AI and big data in the title of the talk where the speaker went on to say a huge list of entirely sensible things. And I just want to thank you, and I mean this very sincerely, for coming and giving this talk, because I thought it was absolutely fantastic. And I had the privilege this last week to be in Toronto for a thing on critical care trials during the pandemic, and it had recovery, and it had remap cap and all these other, and ISARIC and all these other things. And the conversations again kept coming back to, how do we build these integrated data systems in the hospitals we work in, across the hospitals, within countries, across countries, and just the inordinate amount of work and planning and thought and everything else. I guess for our context, I'd add one thing. which is that, you said there's no cost to those initial conversations. And I agree, there's no cost to those initial conversations if you already have some of the infrastructure, the diversity of experts, and the rest of it, and the time for those experts, most importantly, especially on the clinical side, to have those conversations. So I'd argue we very much need resourcing to have those conversations and to start those things. I'm sure you wouldn't disagree, but I don't really have a question. That was fantastic. So thank you again.
Thank you. Thank you. I mean, I think that the risk of really focusing on just connecting data flows without being intentional about what you're actually combining and flowing together, there's a real risk there. I think that you might be where we may be going down rabbit holes of patterns. The one thing AI does really well is give statistically significant results or whatever patterns you may find. And so it'll find patterns in whatever you feed it. And it may be finding patterns that mean absolutely nothing from a biological cancer question perspective or an operational question perspective. It may just be patterns in the noise. And so I think that being intentional about what we're actually flowing together is really important.
I know that Dr. Carroll is on the call, and I wonder, would you like to say a word around the sort of the team that is gathering in the data space in COH right now, and the different backgrounds of the people that are coming together for the first time months?
Yeah. So I guess we're very much at the start of this process, and our first job is to get everybody onto we're trying to get them onto the one software system. So some people are on the system called Dendrite, but then other people aren't. And so in terms of linking for trials or anything, it's difficult to do that next step. So that's where we are now. And I guess, a data dictionary is something that needs to be generated as soon as. That's just, and as for a protocol for the manual extraction of data is so important because everybody's doing it differently. So certainly we're at that spot now where we're trying to get everybody onto the one database, and then the next step will be talking from one, so that the breasts can link with the trials and the trial, you know what I mean, so that they can speak to each other. But yeah, I mean, from a positive point of view, there's loads we can do because we're very much, there's loads of room for improvement at a base level. So yes, it's so interesting. Thank you for your talk.
Thank you.
And this team has come together locally just as we need to clarify, our numbers, our numbers of patients that we treat per year, and some of the national metrics that need to be collected for our national cancer control program, and then expanding that out to additional data points that we feel are important. So it's really a really sort of opportune time that you're giving this lecture as to the importance of this. And can I just maybe ask, just before we close up, what do you feel is the most important impact of all of this for patients? Like what tangible benefits do you feel there are from the work that has been done so far in this space in MD Anderson?
I mean, I think, again, going back to the whole hype of AI and whether we can leverage this technology, I think that if we really want to make if we want to pursue questions that are really going to be impactful to our patients, that we can actually translate from a paper just to show that we built a model to say that we can do this and the numbers look great, to truly building models that we can actually deploy clinically with confidence and safety to say we can make these decisions, or we can flow the data and actually allow this to happen. Really, implementing those AI solutions require us to foundationally change how we're flowing our data. As I started with all the noise in the EHRs, the way that we're collecting and generating and flowing data currently has a lot of noise. And I don't know if some of those are contributing to some of the, or I'm probably pretty confident that some of that is contributing to, the news flashes of things where AI completely failed. And I think that, you can't really say that you're feeding it garbage and expecting it to outperform, human performance. And so I think that this is where there is still this leap of not understanding that it'll literally take everything that you give it, I think this is where humans will outperform, because we often, something doesn't look quite right. You'll get on the phone and you'll say, this, I'm reading this in the chart and I'm not so sure. And if you think about all the conversations that you have, or the emails, or what, the communications that you have outside of the system that you're actually feeding AI the information to actually make decisions, you realize why it can't always get it right, because we're having these other conversations that are not documented anywhere where AI is actually seeing that information. And so sometimes there's these disconnects of, this is the information in the EHR, and here's a decision the clinical team made. Well, it's because there's been another loop around that's not documented in the chart that actually led to that decision. And so it's interesting about, what are we actually revealing to the models? And so we need to start to think about how are we going to document those aspects and make it easy as well. And so I think that part of the challenge is that, the more we want to collect and the more detail we want to collect, the more work it is ultimately to the person who's trying to document it. And so how do we make that documentation more refined and less onerous? And I think that's where there's a lot of potential for us to still continue to grow in this space.
That's wonderful. Thank you so much. Maybe we can have a small data team visit you in Texas sometime in the near future.
That would be wonderful. Would be happy to host.
So thank you, Dr. Chung. And just before we close the hour, I might just mention that the next of these seminars is on November 13th, and we have a focus on peritoneal cancers. We have one of our surgical oncologists, Pather Waters, and medical oncologist John Hayes, giving their differing perspectives on the management of peritoneal cancer. So we look forward to people joining us. And I think in light of the hour, we will just close, and thank you again for your great talk.
Thank you. It's been a
Thank
pleasure.
you so much. Thank you.